All right, thank you, Mike. Okay, so this is, I'm going to talk about a couple of different technologies today, laser technologies for glaucoma. And here are my disclosures. I think for me the key is efficiency in the way we're practicing. These are some of my colleagues who have either contributed data that I'll be presenting or maybe even slides from this presentation. So we're all getting pretty busy treating glaucoma, and we know that glaucoma is growing, and our patients are living longer, which makes the challenge even greater. At the same time, we've really recognized that it's patient quality of life we're treating, and for me, that includes the whole patient experience. We're trying to control their pressure, but it's getting harder and harder for me to talk to patients about taking 6 weeks off to recover from a trabeculectomy, or the needs that may be involved with some of the heavier glaucoma surgeries. We want to get our patients off medications, help them avoid side effects from medications that impact their quality of life. Compliance is a constant challenge, and one where we haven't made much progress in terms of pharmacotherapy, and keep our patients out of the operating room and do it quickly, do it in an efficient manner to conserve our resources. So I'll start with a patient here. This is a 58-year-old man with ocular hypertension. And he used latanoprost and forgets sometimes. My go-to compliance question is, did you take your drops last night? People have a little bit of a harder time lying about that one. And so they may say they regularly take their drops, and I say, well, last night? Well, and no. And so that for us triggered a discussion about what else we could do. So he comes in, the pressure's 25 millimeters of mercury. He's got a thick cornea, and if you look, he has a full field, but I'm not so happy about a 58-year-old with an OCT with so much damage. The reason, by the way, he's held on to a full field is he has diffuse retinal nerve fiber layer loss. So probably every point on that field is just a few ganglion cells away from becoming perimetric. And when it's spread out over the field, there are no focal defects. You don't get the focal visual field loss, but the field then goes downhill rapidly. So looking at his pictures, this is his optic nerve at baseline, and that's follow-up a couple of years later. I think you can see there's been very clear neuroretinal rim loss over that period. And again, it's diffuse. He hasn't developed a focal notch. He's just diffusely losing rim, and maybe has lost a third of his rim, still has a full field. So he's in more trouble than he seems. Well, so if compliance is an issue, laser trabeculoplasty is a great solution. We're increasing outflow facility through the trabecular meshwork. We use this for elevated pressure. Primary open-angle glaucoma, of course, we know it does well. Pigmentary, pseudoexfoliation, and then the board's question is always that the angle recessions don't tend to do as well. So I'm going to be speaking about trabeculoplasty, but using something called micropulse technology. And we have all these different ways of describing it, and I'll try a few on you. With continuous wave laser, we're simply applying laser in a continuous manner. And looking here at the heat that is produced, we see that it sort of increases exponentially. What we're doing with micropulse is breaking that laser up into extremely short, 1 millisecond bursts, followed, well, depending on a period of rest. And that proportion of laser on to rest is called the duty cycle, and the overall period over which we're giving laser is the envelope. So with a high duty cycle, we're still going to get some thermal building because we haven't quite cooled down between each pulse. But as you can see, as we go to a larger interval between pulses, so a lower duty cycle, we no longer have that accumulation of thermal energy. And perhaps that's what's causing focal PAS in the trabecular meshwork, or destruction of ciliary processes if we're talking about a transscleral laser. So the concept here is to apply the same amount of energy, but without the collateral damage. So one of the analogies is the anti-lock brakes. This quick on and off and having better efficacy in braking. And another one that I like is, imagine trying to dry something over a candle. Sure, you could dry it by putting it directly over the candle and burning it, but you could also wave it over, allowing it to cool a little bit, never develop any burns, but at the same time achieve good drying. So, just here's an example of how we might calculate the duty cycle. So here we have a laser that is firing for 0.3 milliseconds or 300 microseconds, and then has a break for 1.7 milliseconds. And overall period is 2 milliseconds. The duty cycle, the proportion of time when the laser's firing, is 15%. So that's what we're using in micropulse laser trabeculoplasty. So this is, if you will, an alternative to selective laser trabeculoplasty, and it has been done with many wavelengths. And this is evolving a little bit. It has been done with 810 nanometers, 577, 532. SLT is a 532 nanometer wavelength. Again, the concept is to thermally affect but not destroy the trabecular meshwork. It is repeatable, doesn't show any visible signs, and this is different from SLT. When we fire SLT, depending on our settings, we may see those champagne bubbles. With MLT, we don't see anything, and that's what we're going for. With MLT, there is no postoperative inflammation. Just none. And I look at all these eyes after I apply the laser. I don't see pigment in the anterior chamber the way I do with SLT. Very quiet eyes, and I do not use any steroids or even NSAIDs after. It's just a quiet procedure from that standpoint. Slightly smaller spot size, and while not always important, in some cases where you have a narrow angle inlet, a narrow approach, maybe a phacomorphic component, you can get into the angle. And it's certainly been shown with SLT that performing SLT laser after an iridotomy in someone who was narrow but is now open is a good way to bring pressure down. And with MLT, you're going to have an easier time getting into that angle. And so very safe from that standpoint. And so again, you're just decreasing the footprint. And this is not to say that I think SLT is bad because it has any of these attributes. These are just differences. And you may find yourself in a practice that has both, and you may, which I did at Cornell, and you may, depending on the situation, use one over the other in various situations. So again, it's an alternative. So again, here's just to give you an example, the spot size, 300 microns being applied over the trabecular meshwork here. And here's a video from Ike of him performing his MLT, and this is what it looks like. So again, you're not seeing any, and this is always tough to capture, fantastic gonio video, but you're not seeing any blanching. You can't see the marks after the laser's been done, and the patient will have a quiet eye. We can also look at histopathology, the trabecular meshwork, or electron microscopy, the trabecular meshwork, and we can't find any visible differences after the laser's been applied. So, we're counting on the biological theory, if you will, for efficacy of laser trabeculoplasty, which is, through inflammatory mediators, recruitment of macrophages, and sort of this general cleaning up of the angle. Some of the evidence for SLT that this is the mechanism is the fact that you do get a little bit of a bilateral effect from laser trabeculoplasty, so the other eye has a modest but statistically significant pressure reduction after the laser, and maybe that's because the immune system's been activated bilaterally. So just to show you now what the laser looks like, here is, these are our current micropulse settings. I'm not sure they won't change, but I think we're all feeling comfortable using these settings. The power is 1,000 milliwatts. The duration is 300 milliseconds for the entire envelope. And then our duty cycle is 15%, which is 0.3 milliseconds of laser followed by 1.7 of rest. So that's what we're using these days. There is evidence of dose response, and this is Dr. Gossage's data. You see a better pressure response as we increased up to 1,000, and that's why we're at 1,000 today. And you can see getting between 20 and 30% pressure reduction once you're up to 1,000 milliwatts. And again, still perfectly quiet. And if you fired a test pulse of continuous 1,000 milliwatt laser onto, say, a piece of paper, it's going to smoke. And if you turn on micropulse mode, it doesn't. So it's, this isn't a slight difference in terms of how much heat's being generated. It's a profound difference. This is some data that a number of us put together. Ike Ahmed, myself, Steve Vold's data in there, and who else did we have? Dr. Gossage. Dr. Gossage is here. All of us pooled some data, and here's what we have. We have baseline pressure around 24 millimeters of mercury, and getting up to a year. Now, there's some dropout here, and there's all the methodological constraints that you see with that, but we see the patients still around 24% pressure reduction up to a year, and as you can see, it's pretty stable from 1 month on. So, we're feeling good about this. Now, as you can see in this study, not too much in terms of tapering the medications. Now, this was the patients with a pressure above 21 millimeters of mercury. When we looked at a subgroup of patients who had a pressure just above 18, you see a slightly lower drop in pressure, which is to be expected because the single best predictor of pressure lowering from any therapy has always been baseline pressure. But now you're getting closer, closer to 20% pressure reduction at a year. And maybe not statistically significant drop in meds, but there was a drop in meds. So again, what are the pearls? Well, I've told you most of the settings. And I have places where I like to use this the most. Given its sort of remarkable safety profile, if I have a patient who has this adverse effect from taking eye drops, that's not as safe as this therapy, which I haven't encountered any safety problems with at all. So that's someone who gets offered to get off a drop, try the laser. And that's, a home run for me. Getting patients off a single agent with this therapy have done very well, and I monitor them. You do have to remember that laser trabeculoplasty in general works a little differently than drops. Not all drops work at night, but laser does. And laser works in the supine position. So, okay, maybe they had 25% pressure lowering with their drop, and then you got them 20 with a laser. I'm willing to wait and see how that goes. I won't necessarily have to drive them back to where they were with the drop, because I know the laser, there's no missed doses with the laser. There's no pressure fluctuation from being 4 hours late on an application of a drop. And so, maybe that will do just as well. Even if the number isn't, as quite as low as the drop had it. So here's a patient who's got a pressure of 20 millimeters of mercury on 3 drops. And, you look at this is more severe loss. Let's look at the left eye, superior arcuate. Fixation is being threatened here, to be sure. That's a dense scotoma right near fixation. Is this someone who needs glaucoma surgery? Quite possibly. But now again, with a quiet laser, I'm less concerned about getting a pressure spike in a nerve that's already very damaged, and so I can be a little bit more liberal. Even though I'm kind of up against a wall on 3 drops with the pressure 20, I can do trabeculoplasty here and not have to worry that I'm going to hurt the patient, and also feel comfortable that I should get something out of it. Whether it keeps them out of the operating room or not, doesn't stop me. I think even if there's a low probability, I just discuss it with the patient, and I think they appreciate it when we work to try to keep them out of the operating room. And that's, when I diagnose a patient with glaucoma, I tell them that's one of our life treatment goals, is to keep them out of the operating room. So that's MLT. I use it for patients who have lost some effect from their meds over time. Patients who've had other lasers are candidates for this, and Dr. Gossage has shown that. Previous ALT is fine, narrow angles for the smaller spot size, and patients for whom you're worried about inflammation or pressure spike. Benefits to the patient, money, quality of life, and again, you don't have to worry as much about compliance. Of course, it's a laser that will have other functions in your office, can be used for iridotomy and retinal applications as well, as you can hear at the forum over the weekend. So now I'm going to switch gears a little bit and cover the other side of the glaucoma spectrum, which is the more advanced glaucoma. And I think that transscleral cyclophotocoagulation is something that really has not gotten the fairest of shakes in glaucoma, and I want to just talk a little bit about it. So here's one of my progressing patients. This guy couldn't tolerate a single eye drop. I mean, just everyone gave him a new set of symptoms. He progressed and progressed, and for him, this was several years ago, was offering him incisional glaucoma surgery, and he was petrified of that, and eventually came back with his field wiped out and with a vein occlusion. Maybe I could have offered him something other than incisional surgery. I'm actually going to come back to that case in a minute, but if you actually compare trabeculectomy to transscleral cyclophotocoagulation, the comparison might surprise you. We get 50% pressure lowering with trabeculectomy, and in many studies, a similar level of efficacy with transscleral cyclophotocoagulation. Both of them have some risk of pressure of the vision getting worse. Trabeculectomy, it's the choroidal hemorrhage that really can be very problematic. With transscleral cyclophotocoagulation, it's inflammation. You'll see in the literature risk of ptysis, and I put that in there with a question mark because there's a problem with the literature for transscleral cyclophotocoagulation, which is that it's been studied disproportionately in very sick eyes that have often failed multiple other surgeries. Where I see real advantages to transscleral cyclophotocoagulation is it's done in the office. The decision to do the procedure can be done right there, and you can have the procedure done several hours, minutes really, after the patient presents, depending on how your office works. And there are no post-operative restrictions. So again, you can have a patient come to your office with a pressure of 40, you can treat them there and then they can go do whatever it is they need to do the next week. Very different from trabeculectomy. They come in, they need to see their primary care doctor, they need to stop their anticoagulants, coagulation medications, and then have the surgery, and then it's unclear how much time they may need off, right? If everything goes well, they could be back to work in 3 days, and if they have chronic hypotony, it could be a month. Transscleral cyclophotocoagulation could be performed with the Iridex 810 nanometer lasers. There's the well-known fiber optic handpiece, the G-probe. And again, this is a procedure reducing aqueous production. I find it fascinating that so many of our topical agents for glaucoma, beta blockers, alpha agonists, carbonic anhydrase inhibitors, decrease aqueous production, and yet it's not something we routinely reach for when it comes to surgical therapy. And I have all my surgeon friends tell me that, theoretically glaucoma is a disease of outflow and we should address that pathology. Well, but we seem to do really well when we address aqueous production with eye drops. What's different about a surgical approach? Transscleral cyclophotocoagulation is really unique though because it's repeatable and it's titratable, and specifically there's no procedure that CPC can't follow, and no procedure that you can't do after a CPC, so it fits anywhere essentially. And it can be done under topical or local anesthesia, and for me that's most commonly a retrobulbar block. I've gotten quite comfortable at giving these in the office. I go under the conch, 25 gauge needle, and do very well with that. So, you know, the indications are very broad as well. You know, and I've been thinking about this a lot this weekend. You know, we have these MIGS options, and then they're only, you know, indicated for certain diagnosis codes. And then there are just some therapies that are incredibly versatile. And again, there's no type of glaucoma that can't be treated with CPC, and many types of glaucoma that can only be treated with CPC. Again, these patients who are unable to undergo standard surgery due to medical problems, and for me, the very elderly fit into that category. You know, if there's a big fall risk and you're considering a surgery where you're, you know, maybe doing a trabeculectomy where, you know, blunt trauma to the eye could be devastating, that's going to shift the direction in the approach towards something like this. Of course, neovascular glaucoma as well. But in my practice, I'm moving it forward in the treatment paradigm, and I'll show you why in a few minutes. So it can be used after a first failed trab or tube, and again, in special situations as a primary surgical procedure, and that's, you know, the 93-year-old who, you know, I had a nice woman who didn't have anyone to come pick her up from the hospital, and we couldn't get her, you know, a trabeculectomy or a tube for that reason, who did fantastically well with an in-the-office diode laser. It can be used in eyes with good vision. I'll show you some data on that. And what we're doing is just playing around with the settings a little bit to try to increase efficacy and decrease inflammation, essentially. And of course, it can be combined with anything, including minimally invasive glaucoma surgeries. We are coagulating the ciliary processes, you know, and here's a ciliary process that's, for lack of a better word, you know, exploded. We don't need to do that. That's if you use a strong setting like 2,000 milliwatts and in a more pigmented eye. But we can also do a treatment that's just more of a slow burn that doesn't cause this type of damage to ciliary processes. I think you may be familiar with the G-Probe, but this is the laser delivery device. It's designed to help you space out your laser applications 1.2 millimeters posterior to the limbus. I just want to again, you know, point out, and maybe I'm sort of covering this topic in too much depth, but if you look at some of the benefits to CPC, there are things you're familiar with from MIGS. You know, rapid onset, can be performed in the office, repeatability, non-incisional, and the issue with anticoagulation. So Jeff, well, a number of investigators have looked at transscleral cyclophotocoagulation in eyes with good vision. This is 43 patients, and patients with 20/60 or better vision loss, 18% of them had some vision loss. Now, in the aegis, 40% of eyes with ALT or a Trab had 3 or more lines of vision loss. And if that sounds like a lot, tube versus trabeculectomy study, 2 lines of vision loss, 30 to 40% in both the tube and the Trab group. So we do lose visual acuity with incisional glaucoma surgery, and yes, we can also with this laser, but actually when you compare, it actually does better, and I recognize that that's maybe surprising. Looking again of a 2-line reduction in visual acuity, this is now a review. You see varying levels, again, 10%, and I guess we got up to 47% in the Schumann paper. And again, as I said, there's been studied in very sick eyes, eyes with vein occlusions and arterial occlusions, and so you want to make sure you know what data you're dealing with. But again, in the tube versus trabeculectomy study, yeah, here it is, 46 and 43% of eyes lost 2 or more lines of visual acuity. And that's not even counting other things that happen, right? Return trip to the operating room. 15% of patients had persistent corneal edema after tube in particular, but even I think 5% of the trabeculectomy patients had persistent corneal edema, that's going to need a corneal transplant. In comparison, transscleral cyclophotocoagulation actually starts looking really good to me. Ike made this point, Ike Ahmed, and this is his slide, but you know, this problem of a snuff out after filtration surgery is a real one. We have eyes with very advanced glaucoma. This is a 10-2 visual field of someone who's losing fixation. Just a little tip here. See if I'm... This is the foveal sensitivity, and a normal foveal sensitivity is 32 decibels, and that'll tell you when the visual acuity is going. Patients may still have 20/30 vision if they have 28 decibels, but 28 decibels isn't normal. And when they start getting into 20 decibels, 15 decibels, their vision's going to drop 2100, 2200. If I have a 2100 eye with a lot of field damage and a cataract, and I'm taking a cataract out, I look at the foveal sensitivity, and if that's reduced, cataract shouldn't do that. It usually means the glaucoma's already come for their fovea, and that can be very helpful in terms of managing patient expectations following cataract surgery. So again, the technique, and this is an easy procedure to perform from a technical standpoint. You have to use a lot of thought and judgment in the management and when to do it and who to do it on. But essentially, you apply your, for me, retrobulbar anesthesia. You place the G-probe flush against the sclera, lining up the anterior aspect of the G-probe with the limbus. You can apply 15 or however many you think is appropriate laser spots, and again, that'll depend on your settings, you know, and how much energy you're using. The G-probe helps you figure out where to place the next laser based on its width. Doug Gasterlin has developed a technique that's called the slow coagulation technique, and essentially what he does, whereas we used to use maybe 2 watts for 2 seconds, he will decrease the amount of power, more so in pigmented eyes, and go for a longer duration. And you may be applying a little bit more energy, but you can see that there's just less of a impact in terms of inflammation on the eye. This difference between the brown and blue eyes is quite a difference. And that's where, you know, I'll caution you is if you have a patient who used a lot of energy, give some thought to how pigmented their eye was. You know, if the next patient you're treating has a very pigmented eye, you know, you may want to be cautious with how much energy, because the heavily pigmented eyes absorb more of the laser energy, they have more of a thermal response, and they have more inflammation. And that's where you might get CME and things like that. Again, you know, neovascular glaucoma eye with a failed tube, great candidate. Here's a patient with a tube that got clogged with vitreous or fibrin, good candidate for this laser. Here's a tube with a big hemorrhage. Clogging it may resolve, but again, these are problems you're not running into. Silicone oil is, you know, just makes filtration surgery impossible, particularly if it's in the anterior chamber. It's a tube clogged with silicone oil. And for me, this is a diode eye. I did have one patient with albinism who had silicone oil, and at least I was unable to get the 810 laser to work because there's no pigment in the eye. And so, you know, you do have to think about it a little bit and think about the mechanism of the laser. So, you know, there is, maybe that's the one case where you couldn't use it, but I really can't think of many others. Keratoprosthesis eyes, lots of conjunctival scarring, and these are eyes that do very well with cycloablation. So again, just the data. This is 74 eyes undergoing transscleral cyclophotocoagulation. They got 43% pressure reduction. Most of them had a reduction in their drops. 13% of patients lost vision, some due to cataract and some due to glaucoma progression. I would list cataract formation as a potential side effect of this laser. Most of the patients we're talking about with severe glaucoma are or become pseudophakic, so it doesn't tend to limit my ability to use the laser that much, but it's definitely something you want to talk to a phakic patient about, particularly if they already have early cataract going into it. And again, in this series, no cases of hypotony or ptysis. This was a study, one eye of 92 patients got actually a very soft transscleral. So they went with a lower energy, but they kept the duration a little short. I would have gone longer on the duration, particularly if I was only using 1.5 watts. But followed for 13 months. Half the patients got a 20% pressure reduction, so that's pretty good. And most of the patients, or about half, got the pressure below 22. And they had a similar number of patients who lost vision from the laser as those treated with medical therapy. So again, this doesn't look like the laser was responsible for the vision loss. Okay, and I'm actually gonna, I don't want to hit you with too much data here. So again, in summary, I think, with transscleral cyclophotocoagulation, it's a versatile therapy. It's one that can work into your practice quite well. And the concept here is, if someone can be helped to avoid a trip to the operating room, it's worth doing and it's worth pursuing. It's not that this is the only therapy I use for glaucoma, but it's something I'm very happy to have available to me. It's non-incisional, really rarely contraindicated, repeatable, titratable, and I do that with patients. I say, I'm not going to go very heavy with the laser on your first treatment. Let's just see what happens. And again, patients are different. A patient who lives a block from your office and is retired would probably be very happy to take that approach to treating glaucoma. And someone who lives far away and has to travel a lot and has difficulty finding transportation, you may want to go more aggressive. And patients are happy to discuss all of this, but you have all those options. So I think based on its safety, efficacy, it deserves consideration earlier in the treatment paradigm. It does compare favorably from both a safety and an efficacy standpoint to trabeculectomy, which is considered by most to be the gold standard, as well as tube shunt surgery, which is the emerging, next gold standard. So I think just deserves our consideration. And then just quickly going back to MLT, it's a great trabeculoplasty option. The laser is multifunctional, so again, this might be a laser that you get for a satellite office where you have a retinal surgeon, a comprehensive ophthalmologist, and a glaucoma doctor, and everyone will be using this laser. Gets pressure up to 30%, 20 to 30% was overall the data that I showed you, in a very quiet manner, small spot size, and again, efficient because it's a slit lamp adapter that can go just on the slit lamp that you use in your clinic. So with that, I'll thank you for listening, and I'm happy to take any questions.
If there are any questions, I can hand you the microphone here.
It's for MLT. How much you can repeat it?
I know
it is new.
I might ask Dr. Gossage to comment on that. He's been using it the longest, so he's.
Yeah, right now we just looked at our 2-year data. We're anywhere between 22 and 26 months, kind of about 24 months. Pressure reduction right now is about 24%. So we did have a little fall off from the 1-year data, which was 26%. So we did drop down to about 24%. If you took out the people that were non-responders, it would have been about 28% reduction. So those people that failed response or their pressure kind of went back up, we can retreat those. And you can go ahead and use the same power settings. Some of the earlier cases that we did with the 300 and the 700 milliwatts of power, most of those patients ended up probably being retreated if needed, if the pressure was rising, because those people have a tendency not to get as much pressure effect that you wanted. And so we ended up retreating them. We had no issues with any retreatment, and we saw a nice effect. Especially, I remember we had one patient who had like a pressure of, I think, 26. Treated with 700 milliwatts power, dropped it down to about 22, and then I hit her with 1,000 milliwatts power and dropped it down to 18. So you can see some added effect, obviously. I'm still debating on trying to maybe think about going up higher in power, but the concern you have, though, is we know from looking at the histopathological slides and the EM scopes that with 1,000 milliwatts power, we're still safe. We're not seeing any thermal uptake. And the other thing, too, is it's kind of interesting. You can I don't know if you ever tried this, but you can take the micropulse setting of the 300, 300, 1,000, 15% Dewey cycle, and you can do a great iridoplasty with it. So if you need to open up that angle a little bit, and so if you thought, I'm doing some homeopathic dosing of laser, but when you hit the iris, you'll see it move, and it makes a nice iridoplasty because it doesn't create the scar that you see if you did traditional conventional wave laser iridoplasty. Because I have a patient that I actually did continuous wave laser on the one eye to open up the angle a little bit so I could do the micropulse treatment in. And then when they came back, I said, I wonder if I could just do it in a micropulse mode. So I did the other eye that way, and it's kind of interesting because you can see later on the atrophy within the peripheral iris where you did continuous wave laser to open up the angle versus that of micropulse.
It's fascinating and makes a lot of sense.
Question, what about the hypopigmented trabecular meshwork? Does it work the same like pigmented, or?
My answer from my experience is yes. I don't think we've formally looked at the amount of pigment, but again, say you had someone with 4+ pigment, even SLT, you'll get a proportional pressure spike in the short term, and that's something I'm still not seeing, with MLT, even in patients with a good amount of pigment in the trabecular meshwork. And I haven't made any observations in terms of correlating that to response, but it's a good thought. I do try to treat more heavily in the areas that are pigmented, and maybe that's superstition or habit. I'm not sure. I'll give 100. So it's like a 360-degree SLT. Yeah. Oh, like right next to each other? Well, right, not overlapping, and there is a space in between them. Yep. Sure. Diode. I certainly have, and I've had an amazing response. I do think that, one of the sort of relative contraindications is if you have an angle that's 100% occluded, it's sort of like shouldn't matter how much you reduce aqueous production because any aqueous production for that eye should be too much. And yet I've done it in some eyes and had a great response. So, I tend to use very heavy settings in those patients. They almost always have a reduction in their central visual acuity. And again, then it's a little bit of a discussion with the patient over whether they want to go to the OR and have something like an Ahmed valve, or whether they want to try something it's sort of less of an ordeal first. So, diode, yeah. I mean, yeah, I do the diode. Again, there's a little bit of, well, what's my probability of needing to repeat this? But in that diode, you can go in a no light perception eye, you can go very high on the settings. I think you can risk ptysis if you overtreat those patients. 25, 2.5 watts, 20 for 2 or 2.5 seconds for 20 applications. I mean, that's about, that's in a no light perception eye on everything with a pressure of 40, is probably where I would go. Yep. Yep. Yeah. 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 I would do an Ahmed now, you know. So I would shift gears on that patient. Oh, with no light perception? Well, it gets into the conversation about enucleation, you know, and then, oh, no pain? Oh, well, let him go, yeah. Yeah, sorry. No pain, right. So no, I mean, I let people, look, if their pressure's 16 and no light perception eye, you know, I might not even have them take drops if they aren't having any pain. If they're having pain, then we get into the, you know, enucleation versus, yeah, right. All right. Thank you.
Thank you.